So everybody, thank you for joining this first international symposium. I think of its time. I really want to give my congratulations and thanks to all the fantastic people who developed this, and particularly to Dr. Presno, who I've been watching work on this for the last few days quite diligently. I'm very excited, and I hope this is the beginning of many more set symposiums so we can start sharing the thing that we've learned in the United States and other countries with the rest of the world. I think it's going to be useful to try to get everybody practicing cancer rehabilitation at the highest possible level and to see if we can overcome some of the barriers that may exist to actually practicing cancer rehabilitation at a high level. So from my point of view, my biggest disclosure is that I'm a wildlife photographer, mostly birds, when I'm not pretending to be a doctor. Um, the other one is my third edition of Principles and Practice of Cancer Rehabilitation will be coming out early next year, and I'm honored that Dr. Presno has helped author 2 of the chapters of the 93 chapters in this book, which will be even better than the last one, as you would imagine. So what I really want to do today, and you guys will have access to these slides, so I'm not going to read everything. I want to be conscious of the time. I also want to be conscious of the translation. So you'll be able to go back and review some of these. But it is critically important in general for all of you to understand at least the basics of breast cancer and any other type of cancer that we're treating. It's really the foundation of rehabilitation. And it comes up constantly that you can't make good decisions. You can't provide safe and effective rehabilitation without really understanding the oncology of your patient. You need to know where they are in the course of their cancer, what the treatments are, and what those treatments are causing in terms of side effects that you can address. So this is just looking at the incidence of breast cancer in the world, and you can see that the developed countries, probably due to diet and other things like the United States, much of Europe and Australia, some Latin American countries have a much higher incidence than some more underdeveloped countries. That said, the death rate from cancer, even though it's higher in, say, the United States and Australia, tends to be lower in those countries owing to the really good treatment options that we have. In other countries where they may not have as good of treatment options, those mortality rates are higher. I'm very hopeful that over time, we're going to get better at providing those treatments to everybody and hopefully further preventing the risk of cancer. So here, and you'll forgive me that most of the data I'll present today comes from the United States. But in this situation, you can see that breast cancer here in gray, since really 1990 or so, has been trailing off quite steadily. And I've even heard some very prominent oncologists say that they expect that in their career, and certainly the lifetime of most of us on this call, that that this will no longer be killing people, right? That I think we're moving into a state, particularly in the developed countries, with the technology where we will be able to effectively cure most breast cancers, hopefully in the next few years. That's exciting. I don't know if it's true, but I've heard it said. So in terms of the risk factors, well, age. Cancer in general is a disease of the aged. The older you get, the more likely you are to have cancer of various types. Family history, absolutely. And there's some well-known genes, like the breast cancer 1 and the breast cancer 2 gene that confer a very high risk, and a number of others you can see here. Highly dense breasts are a risk factor. Biopsy-confirmed hyperplasia is a risk factor, and a number of estrogen-related factors, like when you started having your first period and that sort of thing. And then there's some modifiable risk factors, those that you can do something about. So obesity, which is epidemic in the United States, is a risk factor. Postmenopausal hormonal therapy, being inactive, drinking lots of alcohol, and exogenous estrogen, because estrogen stimulates several types of breast cancers, is also a risk factor. In terms of sort of prevention and screening, I'm showing you this just so that you know there are guidelines, but these guidelines change often and to the confusion of many clinicians. So what I learned when I was a medical student and then a resident and even in the last 5 years keeps changing. That is partly due to the subjectivity of trying to decide where we're going to draw a line to save the most lives with the least cost and the least side effects. So screening, for instance, mammogram is not entirely benign. There's a very small dose of radiation, though with better technology, that dose keeps getting smaller and smaller. And then the treatments that we use to prevent it, like the selective estrogen receptor modulators, those have their own side effects, as we'll talk to some degree. So in terms of diagnosing breast cancer, so for cancer in general, with very rare exceptions, you always need tissue. You need a biopsy of the tissue, and that serves several things. As you can imagine, the treatment for a breast cancer is very different from the treatment from lymphoma or pancreatic cancer or a sarcoma. So we needed to know what it is. But even more than that, we're now able to get very specific about the receptors on that cancer that drive it to grow. And you'll see in breast cancer, we often use that genetic difference in the cancer against it as a way to treat it or really slow the progression. So you always need to have a biopsy, and there's several ways to do that and to get the tissue. Once we have it, we can classify the breast cancer in a number of ways. So the first one is non-invasive, meaning it hasn't broken through yet the containment that's holding it in there, be that a lobule or another structure in the breast. So those two are called lobular carcinoma in situ and ductal carcinoma in situ. Those are breast cancers, but not invasive breast cancers, and have a much lower likelihood of progressing and killing the patient, particularly if you get them early. Invasive breast cancers are a different story. They've now broken outside of the confines of the lobule or the tube, wherever they were contained, and now are at risk for spreading through the lymphatic system and the blood system and metastasizing to other parts of the body. So when you're looking, when you have a patient with breast cancer, you really want to know, was this an in situ cancer or was this an invasive cancer? Is just the first level of knowledge. Why? Because when you're seeing that patient 3 or 5 years later, an invasive cancer is much more likely to come back than an in situ cancer. So when they develop a new symptom, say back pain, could that be from the cancer? Your suspicion would be very low if it was a non-invasive cancer. But there's much more to the story than just that. The two most common you're going to see are the ductal and lobular invasive carcinomas. Then you want to know the stage of the cancer. And this is also very critical for understanding if a recurrence is likely in a patient. So just a patient with an early stage 1 breast cancer has like a 99% 5-year survival. They're very unlikely to die as a result of their cancer. And the way we determine the stage is looking at what's called the TNM classification. So T stands for tumor. It's how big the tumor is. Is it a tiny little less than 2 centimeter tumor? Is it bigger than 2 centimeters, but not bigger than 5, or is it greater than 5 centimeters? If it's greater than 5 centimeters, that's obviously much worse. Those cells are more likely to be abnormal and have the ability to metastasize. Then we look at the lymph nodes. And is there any lymph node positivity, just one, or is there a big mat of lymph nodes that are positive? That gives us the nodes. And METs is just a 0-1, right? So if you have a MET, you're automatically stage 4 if you have a metastasis outside of the lymph node. So this is just showing you more of a graphic representation. So stage 1 would be a small little tumor that we can usually get out. We'll probably sample the lymph nodes to make sure that it hasn't snuck out and got into them. And we usually do that in the United States with a sentinel lymph node biopsy, where we inject dye or a radio tracer into the lymph node, see where it goes, and then take out that lymph node and examine it under the microscope. Stage 2 would be a bigger cancer still, right? That 2 to 5 range. Stage 3 could be really any size of cancer, although they tend to be bigger, but now your lymph nodes are involved, and that's a much bigger deal. And stage 4 means it's out in the body. So say you have a breast cancer you're treating for lymphedema who had a stage 1 cancer, right, who develops back pain. I wouldn't go, under most circumstances, trying to force them to get an MRI. It's very unlikely that that's metastatic. However, if you're 3 or 4 years out from a patient with a stage 3B breast cancer and they develop back pain, that is much more worrisome. I have a much higher index of suspicion that back pain can potentially be caused by metastatic disease. And there's exceptions in both ways. Just because you have back pain doesn't mean it's METS, and just because a stage 1 has back pain doesn't mean it's not METS. It just colors your suspicion and your sort of clinical assessment of the patient. Then the receptors. This is our first sort of personalizing the cancer treatment to the individual tumor. So we need that biopsy to see if they have estrogen receptors present, progesterone receptors, and particularly HER2, the human epidermal growth factor receptor. We also look at the histologic grade, and we have a number of scoring systems that gives us a sense of how likely the cancer is to come back. So if the patient has estrogen receptors present, the estrogen in that patient's body stimulates the cancer to grow. If you block the estrogen, you take that stimulus away. We can do that in a couple of ways. For younger women, premenopausal, it tends to be selective estrogen receptor modulators, also known as SERMs, S-E-R-M-S. So those cause a little less of these musculoskeletal symptoms, but absolutely can still cause cognitive issues and other things. If you have an older patient, and some younger patients, we will use aromatase inhibitors, which inhibit the conversion of androgens that are made, in the ovaries and the fat, mud, and the fat in the muscle, and inhibits their conversion, which inhibits their ability to make estrogen that stimulates the cells. And those really have a very significant side effect called aromatase inhibitor-induced musculoskeletal symptoms, aromatase inhibitor arthralgias, and a number of other names. Interestingly, when the SERMs do it, when the selective estrogen receptor modulators do it, we don't have a good name for it, but they do it. I was struggling with this on a patient the other day. I just keep hearing feedback, so be careful if you're not muted, please mute yourself. All right, so then we also look at grade. So grade I liken to a degree of ugliness. So a low-grade cancer cell looks like the native cell. Then it goes up to like grade 4, and grade 4 looks like, messy. It doesn't look like the native cells. They're all very atypical and abnormal. The more atypical and abnormal, the higher grade, the more likely those cancer cells are to metastasize or to recur. That's why we care about the grade, and that factors into things like our recurrence score for these patients. There's a number of therapeutic treatment options, and I'm not going to go into this in depth, but you should know what your patient went through. So in certain situations, particularly large tumors that don't have all the receptors, the estrogen receptor, progesterone, and HER2 receptors, we will also do neoadjuvant. That means before the surgery. So we can do that with traditional chemotherapy, which poisons all the cells of the body, or these targeted endocrine therapies, or things like trastuzumab and pertuzumab, which attack the HER2 negative patients, or HER2 positive patients, and also often clinical trials to see if the treatment's better. Then most patients will go to surgery. We'll talk about that in some detail. And it's important for you to know what your patient had, if it was a lumpectomy or a mastectomy, if they had a sentinel lymph node or a full axillary dissection. Then most commonly, we will give systemic therapy, including chemotherapy that poisons everything, hormonal therapy or trastuzumab, Perjeta, and now more commonly, things like these targeted agents, the immune checkpoint inhibitors like pembrolizumab to the patient, and also radiation to the patient. And then if it progresses after what we call definitive treatment, then we're kind of back into a number of treatment agents as well. We're not going to go into that too much today just for time. These are some of the agents, and I will encourage you to familiarize yourself with the number of these, and particularly the side effects, right? Because they are all very different. And the way I do it is when I see something I don't know, I'll tend to look it up in the context of the patient in front of me and try to spend a little bit of time memorizing and maybe looking up the side effects, because it's impossible to know the hundreds of agents that have come up. But you should know Cytoxan and Taxotere and Adriamycin and docetaxel, right? You should know these medicines pretty well. They should be, just like you know what aspirin does or you know what paracetamol does, you should know what these medications, the common ones, do if you're seeing cancer patients. What you will also come across in the treatment of cancer patients is acronyms. And I know we've been having some translation issues with the acronyms coming out to be all sorts of entertaining things that I hope we can fix later. But one of the most common you're going to see is Adriamycin, Cytoxan, Taxol, called ACT. That is probably the most common chemotherapy regimen that we will see for breast cancer. But as you imagine, there's a number of others, and it may vary in your country with what is available and what your oncologists like to use and what studies have been done on your specific population of patients. Again, can't overemphasize how important it is to understand if your patient is ER/PR positive. Those patients in particular are going to get these aromatase inhibitors or the selective estrogen receptor modulators, and those cause a lot of potential issues for the patients, a lot of
Ya,
like
ya
side
está bien,
effects
ya
of
está bien.
the medications, the pertuzumab, Perjeta, and trastuzumab, Herceptin, also cause cardiac toxicity as a big side effect. This is actually talking about the aromatase inhibitors. And again, arthralgias are a big problem in these patients, about 30%. We'll talk about that more later. And carpal tunnel syndrome and other neuromusculoskeletal complications are very common in these patients. It's something we see pretty much every day in clinic, and they can be really quite effective or quite debilitating. Herceptin, Perjeta also are medications you should know because they can cause cardiac issues in your patients and may be contributing to fatigue, swelling, and other things like that. All right. So now back to my first bird photo. I guess I had one earlier. So this is an orchard oriole for anybody who cares. So what I want to talk a little bit about is the principles of resection and reconstruction of the breast. This is very important for you to know because so many of the side effects you're going to see in cancer rehabilitation are a direct result of the patient's surgery. So there's many ways to take out a breast cancer. If it's small, say it's one of those ductal or lobular carcinomas in situ, sometimes we'll just do a lumpectomy. That means we take the tumor and a little bit of normal tissue out. It's checked by the pathologist to make sure, and you'll say the margins are clear, and that's good. If it's a bigger tumor, sometimes we'll do a partial mastectomy, and that's really just a bigger piece of the breast tissue that's taken out. We don't generally reconstruct those because we didn't cause so much of a cosmetic defect. In certain cancers, we will do nipple-sparing and skin-sparing mastectomy, but we have to make sure the skin is not involved, and that helps preserve sensation of the breast, as you can imagine, can be very important. Those also will get reconstructed, and we're going to talk about that. Probably more common is a total mastectomy, where they take the entire breast, they take the nipple, they take the skin, and they take the fascia. Modified radical mastectomy means we do that and we do a full axillary dissection. At least in the United States, and probably where you are now, we rarely do radical mastectomies anymore, which would be like a modified, but now we're taking the pec major and minor muscle. And those were very debilitating sorts of surgeries, but because of all of our other treatments, that doesn't help improve survival and it causes a lot of morbidity. So we just don't need to do it. So this is looking at some of the incisions. So this is a scar that you might see for a traditional mastectomy. Here you can see a areolar skin-sparing mastectomy. And here you can see a nipple-sparing mastectomy. And there's a number of ways to do that incision and then shell out the breast tissue. So these are some very nice cosmetic effects for nipple-sparing mastectomy. It's not as common because that skin can harbor breast cancer cells. So it really needs to be a very highly selected group of patients. But as you can see, and of course, surgeons always want to show their absolute best reconstruction. So here are their best reconstructions. Skin-sparing mastectomy. Now you can see the scar lines here, and often these nipples are tattooed back on to make it look like you have nipples. And this does help preserve the sensation of the breast. than a simple mastectomy. This is probably the most common that we see. This can be done with sentinel lymph node biopsy. If it's a full axillary dissection, it's really called a modified radical dissection. And then here's a modified radical. You can see no breast. This patient hasn't been reconstructed. And then here you can see her whole pec major muscle is gone. So this is a radical mastectomy, which you have to dig into the archives to find these because they're just not commonly done anymore. Now, I mentioned about the sentinel lymph node biopsy. This is a new, in the last couple decades, new technology where we will inject something into the tumor and it will be taken up over time into the first lymph node that tumor is draining into. We can then sample that lymph node and make sure that there's no cancer cells in there. If there are cancer cells in there, then we may do an entire axillary dissection of level 1, level 2, just to make sure that there's no cells. And that really dictates if they're going to get radiation in the axil after treatment and a number of other things. So it's a very important technology that leads to, much more easily tolerated breast conserving type of therapy. Then, if those lymph nodes are positive, we may take out the axillary lymph nodes, which are in levels. So level 1, level 2 up to the pec, level 3, we really don't get to very much anymore, and level 4 is up by the spine. And it's very important for you to know that when the surgeon is doing these lymph node dissections, they're not going pick, and just taking out individual lymph nodes. What they're doing is resecting a fat pad between anatomical markers. So they'll take out everything between, this and this, and then send it to the pathologist, and the pathologist then will tell you how many lymph nodes are in there. And generally, for a modified radical dissection, it's level 1 and level 2 lymph nodes that are taken out. Then we go to reconstruction, and there's several ways to reconstruct a breast, and it changes constantly as our technology improves, our surgical skill, our microsurgical techniques improve. So here in the United States, it may be very different. You may not do a lot of reconstructions wherever you are. So one of them is the implants, where it can go straight to an implant during surgery, but more commonly we see a tissue expander, and that is like an artificial breast that's placed either under the skin on top of the pec, or when I was at Sloan Kettering, underneath the pec, and then you will blow that up with saline. We're getting some feedback from somebody, if somebody can mute them, and that will be blown up, right, a few cc's at a time until you get enough pocket that you can reconstruct the breast. Then we do now a number of tissue transplantations. So all of these are with flaps. So a flap, remember, has a blood supply. It can either be pedicled, where the blood supply is attached to wherever it came from. So you can take like the rectus abdominis muscle, keep it attached to its blood supply and tunnel, and I'll show you illustrations of this and sew it in. Or you can physically take it out of the body, eviscerate it, and microsurgery it in. Those are becoming much more common, at least where I am here in New Jersey, and there's several types of those. So this is just showing you a tissue expander. In this case, the tissue expander is underneath the pec muscle. We're seeing more of these done on top, and we've gotten better at doing it that way without complications. And you'll put in a few cc's, as much as the patient can tolerate, until you get up to the size. Then you take that out at a second surgery and swap it for a definitive implant, which will stay with the patient for many years until it needs to be changed. These are TRAM flaps. So TRAM is transverse rectus abdominal myocutaneous flap. And what you're seeing here is you're taking the skin and the muscle, right? And you can do that as a pedicle, right, to sew it in and reconstruct. So you can see here's the pedicle, and here it is sewn in to reconstruct. Or you can take that out as a free flap and physically take it out of the body and then sew it in to reconstruct. And as you can imagine, on the first one, when you're taking the muscle, now you got muscle problems, right? When you're not taking as much muscle, you'll have a little less issue. But I've seen patients get lymphedema below the level. They can have scar pain. They can have a number of issues at the graft harvest site, resulting from this type of surgery. And Deep, one of our surgeons that we work commonly here, is done, I don't know, several hundred of these deep inferior epigastric perforator flaps, which is very similar to the tram, but you don't touch the muscle. You take this deep inferior epigastric vessel, physically take it out, and microsurgery it in. As you can imagine, one of the problems here is flap failure. So if you have a patient who's very obese or who's a smoker or has a rheumatologic condition, part or all of the flap may actually necrose because that microvascularly anastomosed connection doesn't take well, and it can clot off, or other bad things can happen to it, and then you can have that fail. And then here's a latissimus dorsi flap. We actually take part of the lat and tunnel it around, usually as a pedicle, to sew it in, and this will often be augmented by a small implant as well as the tissue flap. And then we have a number of drains that we use. These are usually in place for a few days, sometimes 3 or 4 weeks. We'll remove them once they get down to a small amount. But of course, they can become dislodged. You can get seromas where they are, and a number of other issues. I'm getting more feedback, so if everybody can mute them, please. Perfect, thank you. Infections are not uncommon in these patients. I mean, not super common, but enough. You can get capsular contracture, which you can see over here in this woman. You can see the outline of where she was radiated. We'll talk about that in it. You build a capsule around it, and it becomes very painful and squeezing to the breast. They can leak and rupture. You can get rippling, like here. You can see where it just doesn't look normal, right? Because there's rippling there. One important thing I want you to know, because this really is a very common cause of reasons patients see us at Kessler for pain, is post-breast surgery pain syndrome. You can also heard it called as post-mastectomy pain, but that's not a good name because it can happen even if you didn't have a mastectomy. So it's breast surgery of any part, and you realize that the breast is innervated by branches off the intercostal nerves, and when we're dissecting the breast, those nerves can be damaged. So the patient will often have numbness over the breast, both laterally and or medially. They can have numbness going down the inside of the arm. That's the intercostal brachial nerve. It's different. It's in that it doesn't branch like the other intercostal nerve. So it's a good one to know. And it's the extension of thoracic number 2. So, you know, when a resident comes to me and say, oh, their exam's normal, any sensory deficits, it's usually because they didn't look at the breast, which almost always has sensory deficits. But in some cases, we'll have pain because you can form neuromas over those severed nerves. And we can talk about, hopefully Dr. Presno will talk a little bit about how we address those in clinic. An Eastern bluebird for anybody who cares. So then the principles of radiation, right? So there's several ways to radiate. I'm not going to go into all the detail. Happy to come back to give a talk on radiation fibrosis syndrome, one of my favorite things. But just to talk about some of the basic principles. One of the big things you should know is that generally we're trying to cover the entire breast, and these patients get around 50 gray, 5,000 centigrade. We will sometimes do a boost to the tumor bed, and you will want to know if the lymph nodes, supraclavicular and axillary lymph nodes, have been included in the radiation field, because as you imagine, depending on how extensive the radiation is, you're going to have a whole different set of side effect profiles in your patients. So this is just looking how they use these linear accelerator machines to map out the breast. See here again, it's targeting, and you can see the tumor is probably right there where they're going to boost her. And then these are called isodose curves. So you see in this situation, a very beautiful, very nice, not hitting the heart, not really hitting much of the lung map of the breast that's going to get the radiation. This is a boost. So say we did the entire breast at 5,000 gray or 5,000 centigrade, 50 gray, we might then give another 100 centigrade or 10 gray to the tumor bed to try to make sure that the cells aren't. This is constantly evolving because there's always research going on and what the best way is to do this to save cost and to minimize side effects for the patients. To get the heart out of the way, they're doing more prone now with the patient laying down and letting that way it kind of takes the heart out of the radiation field. So again, mostly it's the breast, the scar, and the drain sites if needed. It's usually about 50 gray that they get, usually about 2 gray per fraction. I'll see as high as 60 gray, but usually with a part of that being a boost. We do the chest wall in these patients. You imagine a number of them have the breast resected. So when you're doing the chest wall, you're also often doing the axilla and the supraclavicular lymph nodes, and there's lymphatics in there, and there's veins in there, and there's other structures in there. So here, this is a study we did, but you can see the axilla is getting, the red indicates a higher dose, is getting a pretty high dose of radiation. So this sets the patient up to get lymphedema of the extremity. Radiation to the breast, we're seeing a lot more chest wall lymphedema from the breast conserving therapy, but the traditional extremity lymphedema will be higher if the patient has had radiation to the axillary or the supraclavicular lymph nodes. So anyway, and here's just showing more of the planning this time for a supraclavicular lymph node in here. All of the tissues have a different, and this is stolen from my radiation fibrosis talk, all tissues have a different sensitivity to radiation. So the lung is very sensitive to radiation. So this is the dose, because 50% of the patients have a problem at 5 years. This is the total dose. And there's a lot of other stuff that goes into it. So you see in the lung, it's just 25 gray. Remember, we're giving the breast 50 gray. If you were to radiate the lung at that, half of the patients would have issues at 5 years. If you go to 10 years, a lot more, I think, would have them. But nerve tends to be relatively radio resistant. So for breast cancer, if you keep that dose at 50 gray, you're usually pretty good in the plexus. But again, it's a bell curve. So there's some people who are likely to have issues earlier. So if you give 50 gray at 2 gray to the plexus, your risk of brachial plexopathy is less than 1%. And you can go up on the size of each individual dose so long as you drop the total dose. But if you go up on the size of the individual dose and you go up on the total dose, there are studies that show 73% risk of brachial plexopathy. So we're always trying to calibrate our treatments to give the best cure with the least amount of side effects, both acutely and late effects like radiation-induced brachial plexopathy. I think we'll commonly see radiation dermatitis. And again, you can see her supraclavicular lymph nodes weren't involved, but her axillary lymph nodes absolutely were. And, you know, the skin wasn't the target. So you imagine that everything under the skin has been even more severely affected by the radiation. You can get lung involvement even at a low dose, so you can cause pneumonitis, fever, chest pain. The skin changes usually get better, but not completely, particularly in dark-skinned patients, which I'm going to say is probably the predominance in South America. Other things, you can get fat necrosis, you can have rib fractures, rarely seen. A lot of this is old data. I think the way we've done radiation in the last few years, at least here in the United States, has really risked all of these, but we still have a big risk of lymphedema in these patients. There are some times when you really don't want to do radiation surgery, and when there are radiation therapy, they're more likely to have issues. Skincare, just giving you some things you guys can read later. And for patients with like scleroderma, I've seen patients who've kind of developed scleroderma after radiation. It's really a very big thing. Sorry, we're getting some more breaks. You can move them. All right, so into the home stretch. If somebody can, thank you. So understanding the treatment of breast cancer, understanding what your patient went through, and remember, it may vary in your country and with the practitioners referring to you, is absolutely critical for understanding what's likely to happen. And I'm just going to go through this. So at diagnosis, one of the big things we worry about is what other issues do they have? Do they have diabetes or a rheumatologic condition? Are they morbidly obese? Do they have heart disease? Do they have bad arthritis? So all of these factor into how they're going to do when they get treated. Then when they go to surgery, what kind of surgery? Was it just a lumpectomy of a small tumor and a sentinel lymph node biopsy? Or was it a total mastectomy with a full axillary lymph node dissection? Were they reconstructed? If so, was it a tissue expander to implant, or was it a DEEP or a tram flap? All of those really factor in to where this patient's going to have problems. You can imagine if you had a big reconstruction, it's more likely to cause frozen shoulder. And if you're a sports medicine doctor who didn't take their shirt off or didn't think that their breast treatment was important, you're going to miss many of the things that are contributing to their shoulder issues. Then when they go to chemotherapy, and it's probably better to say systemic therapy because it'll be some traditional chemotherapy like that ACT, but it's also going to be Herceptin and trastuzumab. And now I've seen patients getting these immune checkpoint inhibitors, and I've seen some real devastating issues from the immune checkpoint inhibitors because they really mess with your body's immune system. Then radiation. Was it radiation just to the breast? Was the axilla involved? Were the supraclavicular lymph nodes involved? How much? All of that factors in. And then ideally in my world, I'd like to follow these patients through this whole treatment. And then afterwards, that's going to dictate what kind of side effects you're going to look for. Not just lymphedema, but for recurrences, for post-mastectomy or post-breast surgery pain syndrome, for aromatase inhibitor-induced musculoskeletal symptoms that can come up, after they've treated, and they show up to you with carpal tunnel syndrome from the synovitis that's been caused by their aromatase inhibitor and another other thing. So I think that I'm done. That's a common yellow throat for anybody who cares. I'm going to stop sharing